Assalamu alaikum wa rahmatullahi wa barakatuh. Once again, I'd like to welcome you to the endocrine unit of the internal medicine department. My name is Mona Aboul-Seoud. I am a professor at the endocrine unit of the internal medicine department. Before I start, let me put some ground rules by which all of us should abide all through the session. Please keep your microphones mute at all times in order to lessen the background noises and the echoes. Whoever wants to speak, you can raise your hand, you can unmute your microphone so that you can speak, all right? Of course, I would like to see all of you, like you can see me, but I think if we do that, maybe the bandwidth of the internet will not allow it. So for the sake of improving the internet connectivity and the bandwidth, I will not ask you to open your video cameras, all right? And please feel free. We are all sitting comfortably at home or wherever we are, so you can eat or drink during the session. It's not like in the wards, all right? And of course, whenever you are tired, I can give you a break. But as long as you keep quiet, I can go on. Our session is going to be a little bit long because I intend to, as I'm going to show you in the intended learning outcomes, I'm going to revise the whole of the endocrinology over 2 sessions. All right. So feel free whenever there is something you don't understand to raise your hand and ask me, because I am here for you. All right. And I'm also open to suggestions. Please suggest. If you want something, you tell me, because I cannot possibly know unless you tell me, all right? And again, like with all my sessions, by the end of today's session, I'm going to put a survey or a questionnaire in the chat for you to answer. And we're going to do it online, all right? Any suggestions? Anything you want to tell me before we start? Feel free. Is my voice clearly audible to you? Is my voice clearly audible to all of you?
Yes, yeah, doctor. Yes.
Okay, okay.
صوت كويس جدا.
Okay, تمام, ممتاز. So now let me start sharing my slides with all of you. Just tell me whenever you see the slides, right? Can you see the slides?
Yes,
Yes,
doctor.
Right. Are they small or are they in slideshow?
Small.
Now they are slideshow.
Okay, great, great. So today is my first revision session. And here are the intended learning outcomes, what you are going to take out of today's session. By the end of today's session, you will be able to understand the anatomy and physiology of the hypothalamic pituitary axis. And then you're going to be able to list all the symptoms and signs of hypopituitarism. And you're going to be able to list the signs and symptoms of various pituitary tumors, including craniopharyngioma. And you're going to be able to understand the various imaging modalities in hypothalamic and pituitary diseases. And then you're going to be able to list the symptoms and signs of hypothyroidism, and you're going to be able to detect the atypical presentation of hypothyroidism in children, young women, and elderly patients. And next, you're going to be able to enumerate the symptoms and signs in hyperthyroidism, and you're going to be able to diagnose the presentation of hyperthyroidism according to etiology. And again, you're going to be able to detect the atypical presentation of hyperthyroidism in children and elderly. And then you're going to be able to differentiate the type of goiter in the different causes of hyperthyroidism. You're going to be able to diagnose the different eye signs in Graves' disease. This is very important. And then you're going to be able to describe the different methods of detection of exophthalmos. Again, this is very important. And then you're going to be able to differentiate the different types of thyroid nodules. And finally, you're going to be able to describe the different imaging techniques in thyroid diseases, including thyroid ultrasonography and thyroid scintigraphy. Okay? So far, any problems? Any problems till now? Am I going too fast? Am I going too slow? You just tell me, please.
No, it's okay, doctor. No.
All right, fine. Okay, so let me start by the anatomy of the pituitary gland. You will notice that I have arranged the revision in an anatomical way, the pituitary being the master gland of all endocrine glands, and then sequentially the thyroid and so on. Okay, so regarding the anatomy of the pituitary gland, you know that it lies at the base of the skull. This is the picture in the anatomy books, we all know. So it lies at the base of the skull inside a bony cavity called, in the sphenoid bone, called the sella turcica. This is a close-up of it. So this is the sella turcica, and this is the pituitary gland, right? This is the anterior pituitary. Can you see my cursor? Can you see my cursor, or shall I?
Yes, doctor.
Okay, so this is the anterior pituitary, this is the posterior pituitary, this is the pituitary stalk, this is the hypothalamus, and this is the optic chiasma. All right, so its size is very small. It's around 15 by 10 by 6 millimeters in dimensions, millimeters, not centimeters. And this size may double during pregnancy. This fact is very important, as we are going to see. It weighs only 500 to 900 milligrams. This is nothing new. We know all this from our anatomy. The new thing is that this exact anatomy we can see in doing magnetic resonance imaging in sagittal view on the pituitary gland. So let me revise the anatomy with you. Why am I telling you this? Because in your exams, okay, there will be a station composed of an imaging modality. So this is why you need to know the proper anatomy of each endocrine gland, so that you will be able to know the imaging modality and what it shows. So this is a sagittal view of the MRI of the pituitary gland, or of the sella turcica. And let me revise the anatomy with you again. In the MRI, we have two techniques. At least there are more techniques, but as the pituitary gland is concerned, we have the T1 weighted image and the T2 weighted image. All right. How can we differentiate between both of them? Simply by looking at the CSF. In the T1 weighted image, the CSF, as you can see here, you see this is the CSF inside the spinal cord, and this is the CSF in the fourth ventricle. Okay, this is the cerebellum, the midbrain, the pons, and the medulla oblongata. And here is the fourth ventricle. All right. So the CSF in T1 weighted images appears black, while in T2 weighted images it appears white. So this is a sagittal section or sagittal view of the MRI on the sella turcica or on the pituitary gland T1 weighted image. And the anatomy is as such. Let me remind you again, CSF, flowing blood in arteries, and air appear black. So this is air of the sphenoidal sinus, right? This is air in the oropharynx. This is air in the trachea. Can you still see my cursor? Can you see my cursor?
Yes, doctor.
Yes.
All right. Soft tissue
The
appears gray. All right. So this is this is the nose, this is the upper lip, this is the lower lip, and these are the nasal turbinates. This is the tongue, this is the epiglottis, this is the brain, the frontal lobe, the parietal lobe, occipital lobe. This is the corpus callosum, right? And as I mentioned before, this is the cerebellum, the pons, the midbrain, the medulla oblongata, and here is the area of the fourth ventricle, which contains CSF, so this is why it appears black. Now coming to the pituitary, here is the pituitary gland, right? If you look closely, you will find that the anterior pituitary appears more gray than the posterior pituitary. In fact, the posterior pituitary appears like a bright spot. It appears whiter, without any contrast, without any contrast. It appears whiter than the anterior pituitary gland. This is the normal, all right? This is the pituitary stalk. Here is the hypothalamus, and this is the optic chiasma, all right? Any problems so far? Anything that is not clear? Can you answer, please, for the sake of time? Okay, all right. Okay, so this was the sagittal MRI of the pituitary gland. Like we have a sagittal MRI, we also have a coronal MRI. The coronal cuts are cut like that. Can you see the way I'm cutting along the coronal sinus, right? So let me look at the anatomy again. Here's right, here's left, and this is the area of the inferior to the, let's say, to the sphenoidal sinus, the area where the tongue is, and here's the oropharynx. It appears black because it's full of air. And this is the area of the sphenoidal sinus. It appears black because it contains air, as I mentioned, okay? And this is the pituitary gland. Please notice for later on that the upper border of a normal pituitary gland is either flat, like here, or concave, but never convex. A second important thing to notice is that the pituitary stalk of a normal pituitary gland is central. You see, it's central. It's not dilated. It's not deviated to the right and not deviated to the left. Central. And here's the optic chiasma. And on each side of the pituitary gland is the cavernous sinus, right? The cavernous sinus is a very important structure. Why? Because it contains the carotid arteries. See, they appear black. Okay, it also contains the cranial nerves, the oculomotor or the third cranial nerve, the trochlear or the fourth cranial nerve, the upper two divisions of the trigeminal nerve, the ophthalmic and the maxillary division, as well as the abducent nerve or the sixth cranial nerve. Now, coming to the carotid artery, you will tell me we have one carotid artery on each side, right? But why does it appear double? Who can tell me? Who can tell me? Why does the carotid artery inside the cavernous sinus appear double? Huh? Who can tell me? For the sake of time, if you don't know, just tell me, please, so as not to waste more time on this particular area. Shall I choose? Shall I choose somebody to answer?
Because it's arch.
Sorry?
It's arch.
All I heard is arch, but I couldn't make out anything else. Dr. Tariq, if you can repeat, please. Because of what? Dr. Tariq, I cannot hear you. Anybody else? Can anybody else tell me why? The arc? What arc? You mean the carotid siphon? The carotid siphon? There is something called the carotid siphon. So when you cut the carotid siphon coronally like that, it's going to appear as if it is two structures instead of one, right? So this is why the carotid artery appears double. And as I mentioned before, flowing blood, the carotid artery, of course, contains arterial blood. So this is flowing blood. It appears black. So this is why the carotid artery appears black. Until here, any problems? Anything that is difficult? Okay. So now let's discuss or revise hypopituitarism. Is somebody saying something?
I'm saying.
Yes, who is talking? Who is talking?
It's arch.
Okay, there seems to be lag in the sound. Anyway, so regarding the consequences of hypopituitarism, there are many clinical consequences thereof. First of all, growth hormone deficiency. It causes growth hormone deficiency. Why is that? Because you know that the pituitary gland is the master gland of all endocrine glands, right? And through the through the pituitary stalk, several hypothalamic stimulating and inhibiting factors reach down the anterior pituitary gland in order to stimulate it or to inhibit it, right? So regarding growth hormone in children, deficiency of growth hormone would cause short stature. And until recently in adults, it was said to have no effects, but recently it was found that adult patients suffering from hypopituitarism, they always complain of malaise, chronic ill health, and this was attributed to growth hormone deficiency in adults. Now coming to gonadotrophins, the FSH and LH, they will cause infertility and hypogonadism in males with reduced sperm count, okay? And in ladies, it also causes hypogonadism with menstrual irregularities, right? And coming to TSH, it causes secondary hypothyroidism. Who can tell me what the difference is between primary and secondary hypothyroidism? Is there a difference or not? Who can tell me? I'm sure you have studied all this. Is there a difference between primary and secondary hypothyroidism? Who can tell me?
primary بيبقى المشكلة في الثايرويد نفسها.
أيوة. دكتورة ياسمين أبو حلاوة. Yes. Yes. Okay, go on.
primary مشكلة في الثايرويد، السكندري بتبقى
Yes.
حاجة beyond the thyroid gland.
Yes, in the pituitary يعني central بتبقى central. All right, very good دكتورة ياسمين. Excellent. All right. So coming to ACTH, deficiency of ACTH would cause loss of pigmentation, right, with hypoadrenalism, like we're going to see. And coming to the posterior pituitary, some textbooks, in addition to the anterior pituitary hormones, they add antidiuretic hormone to pan-hypopituitarism, although this is not accepted by all endocrinology textbooks. But just in case, ADH deficiency would cause diabetes insipidus, because we encounter diabetes insipidus in patients with craniopharyngioma. Okay? Patients with craniopharyngioma tend to present with pan-hypopituitarism together with diabetes insipidus, right? Now coming to the clinical features of hypopituitarism, it differs according to the gender of the patient, of course. Women tend to complain of amenorrhea, cessation of menstruation, and infertility. They also complain of vaginal atrophy, which presents as dyspareunia. Dyspareunia means what? Who can tell me? What is dyspareunia? What is dyspareunia? Who can tell me? Can you hear me? Can you hear me?
Yes, doctor.
Yes, what is dyspareunia, Dr. Farouk?
Painful intercourse.
Yes, very good. Excellent. All right, so ladies with hypopituitarism can also complain of vaginal atrophy that presents in the form of dyspareunia. They complain of atrophic breasts, loss of axillary and pubic hair. Regarding male patients with hypopituitarism, they complain of loss of libido or impotence and infertility, of course. And if you examine them, you will find soft atrophic testes, and you will also find loss of secondary sexual characteristics. And in both genders, in both male and female, TSH deficiency will cause mild to moderate hypothyroidism, secondary hypothyroidism, like we mentioned before. And ACTH deficiency will lead to weakness, postural hypotension, pallor, and hypoglycemia. This is very important. All right. Anything that is not clear till now? Let me proceed further. The clinical features or the symptoms and signs of hypopituitarism depend, of course, on the extent of hypothalamic and or pituitary deficiencies. As you all know that secondary hypothyroidism and adrenal failure, both of them lead to tiredness and general malaise, right? While hypothyroidism causes weight gain, slowness of thought and action, dry skin, and cold intolerance. Nothing new. You all know that, right? Type. In hypopituitarism, usually there is hyperprolactinemia. Who can tell me why? Most cases of hypopituitarism caused by a Stoke effect will cause hyperprolactinemia. What is Stoke effect? Who can tell me? Did you hear this term before? Stoke effect. What is meant by Stoke effect? Who can tell me? Shall I choose somebody to answer? What is Stoke effect?
It may be
Sorry?
due to as the prolactin is in always under suppression due to the dopamine.
Yes. Yes, very good, Dr. Mustafa. Very good. So like Dr. Mustafa mentioned, prolactin is always under an inhibitory. There is an inhibitory tone by dopamine secreted from the hypothalamus on prolactin, meaning that it is always suppressed. Suppose there is a tumor that extended upwards to the area of the pituitary stalk. This will cause a Stoke effect. So it will release the inhibitory tone by dopamine, leading to hyperprolactinemia, right? This is encountered in many of the pituitary macroadenomas that extend upwards to the suprasellar region, right? But of course, in a disease like Sheehan syndrome, what is Sheehan syndrome? Who can tell me? What is Sheehan syndrome? Did you hear that term before? What is Sheehan syndrome? Can you please answer me? What is Sheehan syndrome?
It's postpartum pituitary infarction.
Yes, excellent, Dr. Mariam. Excellent. As I mentioned in the very first slide, you remember the pituitary gland doubles in size, right? During pregnancy. So suppose this lady was not following a good antenatal care. Okay, suppose this pregnant lady was not following closely the antenatal care. And it turns out she has a placenta previa, for example, all right? And then she doesn't deliver at the hospital. She's coming from the countryside, and she goes to her husband asks Daya or the midwife to come and help his wife deliver. And all of a sudden, this lady delivers postpartum hemorrhage. At home, there are no facilities to resuscitate her quickly, and the blood pressure drops. She gets into shock, and then until she reaches the hospital to get blood transfusion and proper care for the hemorrhage, there will be what? Pituitary infarction, postpartum pituitary infarction, because the increased size of the pituitary gland in face of the hemorrhage and the shock will suffer from infarction. Okay? So this will lead eventually to postpartum pituitary necrosis, like Dr. Mariam has told us. So this lady will present with what? What would be the clinical picture of Sheehan syndrome? She will complain of what? What is the first thing she will notice? What do you think? You can tell me.
Of lactation.
Yes, the failure of lactation. There will be no colostrum. There will be no breast milk. So there will be no breast milk. Why? Because in this particular condition, there will be actual hypoprolactinemia. Prolactin will be low, not like in the other causes of hypopituitarism, in which there is severing of the pituitary stalk or Stoke effect. Is it clear? Is it clear to you the difference between all the causes of the neoplastic causes of hypopituitarism and Sheehan syndrome? Is it clear to you? Is this difference clear? Would you answer, please? Type. Anyway, I was mentioning hyperprolactinemia. And in this regard, I was talking about the neoplastic causes of hypopituitarism. This hyperprolactinemia may cause galactorrhea. It means milk secretion from non-lactating breasts, and hypogonadism. Okay? And regarding growth hormone deficiency, like I mentioned before, in children, it causes growth failure or short stature. But in some adults, it causes impaired well-being. Okay? And regarding the weight, it may increase due to secondary hypothyroidism, or it may decrease because we have a condition called severe combined pituitary deficiency, or what we call pituitary cachexia. Now, who can tell me the difference between these three terms? What is the meaning of cachexia? What is the meaning of wasting? And what is the meaning of emaciation? Is there any difference, or are the three terms the same? Who can tell me? Who can tell me? Can you hear me? Can you hear me? Yes. Yes.
Wasting of muscle, mostly loss of muscle mass.
This is which?
Loss of.
So Dr. Mustafa says cachexia is loss of muscle mass mainly, right?
لا cachexia, loss of muscle mass and subcutaneous tissue.
Exactly. Excellent. So cachexia means loss of muscle and fat. So what about wasting, and what about emaciation? What does
wasting
each term? Yes.
Wasting is the loss of muscle.
Exactly. Wasting means loss of muscle. So emaciation is loss of fat. Remember from your pediatrics course, when a child with malnutrition is emaciated, you see the buccal pad fat is wasted, is absent. So this is emaciation. While wasting we can see. Yes, tell me, Dr. Mustafa. Tell me.
I wasn't known how to write emaciation. It was the first time I hear this.
Okay, I will write it in the chat.
I was only yeah.
I will write it in for you in the chat. This is emaciation. This is how you write it. You're welcome. Emaciation. I hope you can see it. Can you see the chat? Did you? And this is wasting. Okay. Wasting is not written with an I, because waste is الخسر يعني, huh? Is written W-A-I-S-T. While waste, this is how to write wasting. All right. Okay, so like Dr. Mustafa told us, wasting means muscle atrophy, while emaciation means loss of subcutaneous fat or loss of fat. Cachexia means both of them, loss of both muscle and fat. All right. So this pituitary cachexia, I'm going to show you pictures thereof in a while, is seen in severe combined deficiency of pituitary hormones. All right. And we have seen several patients suffering from pituitary cachexia. Long-standing pan-hypopituitarism, and with this word pan-hypopituitarism, I mean deficiency of multiple anterior pituitary hormones. It gives the classic picture of pallor with hairlessness. All right. What is called alabaster skin. What is alabaster? Can anybody tell me what is alabaster? I'm going to show you pictures thereof in a minute, but can you tell me what is alabaster?
An animal which contains the most content of genome.
No, it's not an animal at all. No, it's not an animal at all.
A lizard.
No, it's not an animal. No. Alabaster is a type of stone. I will show you in a minute. But let me first show you, this is galactorrhea. When I say galactorrhea, it means milk secretion from a non-lactating breast. Okay. Of course, women or female patients suffer from galactorrhea more than male patients. Who can tell me why? Why? You have to always ask yourselves why. Who can tell me?
عشان في memory glands أكتر.
Exactly. Very good, Dr. Yasmin. In order for prolactin to act on the breast, it has to be primed by estrogen, all right? So men have very little estrogen in their bodies, right? So their mammary glands or their breasts, they are not primed by estrogen. So prolactin cannot possibly act on the breasts, although it is written in textbooks, by the way, that galactorrhea can also occur in men. But in clinical practice, we haven't seen this at all, okay? So like Dr. Yasmin mentioned, women, they have primed breasts, well-developed mammary glands on which the prolactin can act. So this is why milk secretion can occur from a non-lactating breast. And mind you, it may be spontaneous. Yani the female patient comes complaining, I have milk coming out of my nipples, although I am not lactating. She can complain of that. This is called spontaneous galactorrhea. But there is also another type of galactorrhea that you as a physician, when examining a female patient, have to look for. It is called expressible galactorrhea. It means when you examine the female patient, you compress the nipple, you squeeze the nipple to see if milk comes out. This is called expressible galactorrhea. If no milk comes out, then she doesn't have galactorrhea. Is that clear? Is it clear? So this is an important part of examination, okay? And this is how pituitary cachexia looks like. All these are female patients. You see, this female, this girl is like skin over bone, like those patients who suffer from severe malnutrition, but she has pituitary cachexia. And these are pictures, this one on the left-hand side and this one. Let me show the cursor again. This one and this one. This is the lady before getting sick, and this is after she developed panhypopituitarism with pituitary cachexia. You see, breast atrophy, there are no breasts almost, and she is skin over bone. And the same is apparent on this picture. You see, this was the girl before developing pituitary cachexia. She had well-developed breasts and muscles and buttocks, fat, okay? But here she became skin over bone, again with atrophic breasts. And this is the same. Is it clear? So this is pituitary cachexia, right? Now, this is an adult male with hypopituitarism. He complained of feeling cold all the time. He was lethargic. He feels dizzy on standing. He is weak and he has constipation. And coming to the signs, if you want to examine the patient, you find severe pallor, not only on the face, but all over the body. He has alabaster skin. You see, a male subject should have chest hair, right? Breast hair or chest hair. He should have hair in the pubic region, hair on the arms, hair on the legs, right? But here, there is no hair at all. Not even in the axilla, not even in the pubic area. And his skin appears pale all over, like alabaster. What is alabaster? This is alabaster, ya Dr. Mustafa. Huh? اللي فيكو, whoever visited touristic areas of Cairo or Luxor and Aswan, you will find that they sell these alabaster objects. These alabaster objects, the ancient Egyptians, they used to preserve the heart, the brain, and the liver and intestine of the mummies, المومياوات يعني, before mummification. They were called canopy jars. They were put in this alabaster. So this is a type of stone. It appears pale yellow in color and it is very smooth. Exactly the same picture like the skin of this male patient with hypopituitarism. Is it clear? Is it clear now, Dr. Mustafa and all of you? Type, what else? This patient, if you look closely, he has wrinkling around the skin and around the eyes, of course, and mouth. And of course, here the eyes are covered for patient's privacy. But if you look closely, there are wrinkles around the mouth of the patient. The patient appears like an old young man, an old little man, okay? And he has lots of secondary sexual characters, no beard, no mustache, no axillary hair, no pubic hair, and he has also no chest and abdominal hair, no hair over the body, and he has no pubic hair. All right, so this is what is meant by alabaster skin. Is it clear? Did you hear this term before? Huh? Did you hear this term before?
No,
Do you
doctor.
still? Okay, fine. Time. This shows you can still learn something new every day, right? Okay. Time. Now coming to remember the initial MRI I showed you, the normal one. Time. Let's discuss an important topic. Maybe last week, I think you had a case of empty cell syndrome, right? If I'm not mistaken. So look closely. This is a sagittal MRI of the pituitary gland in T1 weighted images. How do I know it's a T1 weighted image? Because the CSF appears black here. Okay? Type. Let's look closely. This is the sphenoidal sinus. Air appears black. This is the sella turcica. Bone appears white. And this is the pituitary stalk. If you look closely, where's the pituitary? There appears to be no pituitary tissue. Yani as if the pituitary stalk reaches till the floor of the sella turcica, right? So let's look to the coronal MRI. This is a coronal MRI of the pituitary gland, again showing this is the area of the sella turcica. Bone appears white. Okay, this is the optic chiasma, and this is the pituitary stalk. Where is the pituitary gland? There appears to be no pituitary gland, as if the pituitary stalk reaches till the floor of the sella turcica. Okay, so this is why it is called empty sella syndrome, right? Meaning the sella is devoid of pituitary tissue. Okay, and of course this is a T1 weighted image again. How do we know? Because this is these are the ventricles, okay, filled with black CSF. Is it clear? Any problems so far? Am I going too fast? Huh? Am I going too fast?
No, doctor.
Okay,
Yeah, doctor. No,
great. Type. Now let's shift to acromegaly. Have you seen an acromegalic patient in the ward? Huh? Can you please answer me? Have you seen an acromegalic patient in the ward? Okay, great. Type. Yani I will, do you want me to skip acromegaly or shall we revise quickly? Like you, suit yourself, like you want. I'm going to do what you want. You want me to revise acromegaly quickly or shall we skip it?
please revise it, doctor, quick.
Okay, great. Type.
Thank you.
You're welcome. Type. Now the clinical features of acromegaly, of course, they are composed of symptoms and signs. So first of all, the symptoms change in appearance. And mind you, any disease that has to do something with the external appearance, female patients come running. Male patients, they usually don't pay much attention to their external appearance. All right. So the first thing a female patient would notice, oh my God, what happened to my face? Okay. My facial features became coarse. My nose has enlarged, my lips became larger, and my bones, they protruded, the cheekbones, the supraorbital ridges, and so on, right? And next, she will also notice increased size of hands and feet. She will come tell you, for instance, I had to go to the jeweler to have my ring cut off my finger because I couldn't remove it. My finger became too thick and the ring became too tight, okay? And something else also, she will tell you, I used to wear shoe size 37. Now I cannot find my shoe size and I go buy shoes from the male department. Or I have to have custom made shoes because my shoe size now became 44, you see? And then she will also complain of headaches, in particular frontal and sphenoidal also, this area, okay? She will complain of excessive sweating. Not only that, but she will also complain of excessive greasiness or oiliness of the skin. This can be very bothersome to female patients. She will tell you, I go take a shower like 5 times a day, but still I have excessive sweating, and still my skin all over the body appears oily or feels oily. And this is disgusting, you see. And then she may complain of visual deterioration in the form of diminished visual acuity or even visual field defects, right? She will complain of tiredness, weight gain, amenorrhea or oligomenorrhea, galactorrhea, okay? If it is, if the growth hormone secreting pituitary tumor is a pluripotent tumor. What does it mean, the word pluripotent? It means in addition to growth hormone, it can secrete also prolactin, right? Or it may be due to a stalk effect caused by a macro adenoma secreting growth hormone, right? Male patients will complain of impotence or poor libido, okay? There will be deepening of the voice. This is, of course, appreciated more in ladies because women tend to have high-pitched voices, right? صوتها رفيع كده مسرسع. She will complain. Do you hear my voice, doctor? Yes, I hear it. Type. Of course, you should have an index of suspicion. Yeah. Huh? But then you will ask the patient, what about your voice? She will tell you it became deeper. Let me put the charger before my laptop goes off. Can you still hear me? Can you still hear me? Do you hear me?
Yes, doctor, I hear you.
Okay, great. Type. Because I put the charger, but then it still says closing. I wondered, I was wondering. Anyway, so the lady will tell you my voice became deeper. It became hoarse, زي مغلقة كده أو شنت. Okay. طب why do you think the voice became deeper in female patients? Of course, male patients have this too, but they don't notice, usually. Why do you think the voice became deeper in acromegaly?
Beginning of the vocal cords.
Type. I can't see who answered, but there were two people who were talking. One of them said laryngeal enlargement. Yes, I agree with you. And somebody else said thickening of the laryngeal of the vocal cords. Both of you are right, because you see, if anybody of you is into music, you will notice that, for instance, an orchestra. عارفين orchestra? An orchestra is composed of several musical instruments. There is the violin, soprano. The voice is the sound that comes out of the violin is very high-pitched, right? It has a small resonance box. حجمها صغير، صح؟ The next larger instrument is the viola. It's larger. It has a larger resonance box. So the sound coming out of the viola is deeper in pitch, right? And next comes the cello. اللي بيعزفه وهو قاعد كده ماسكه. The cello. It has a larger resonance box. Okay? It has a deeper pitched voice. And the last one is which one? The cello. اللي هو اسمه ايه الكبير قوي ده contrabass. The contrabass. Okay? It has the deepest, the biggest resonance box of all string instruments, and it has, of course, the deepest pitch of sound. Okay? نفس principle. The same principle applies to the laryngeal box. The larynx is, of course, composed of cartilage and vocal cords. So if the cartilage enlarges in acromegaly, it will cause a deeper pitch of the voice. And if the vocal cords, as part of soft tissue enlargement, thicken, they will also cause a deeper pitch of voice. All right, is it clear? Is it clear? Now goiter.
Yes, يا دكتور.
Some patients, we actually had a patient, maybe you saw her, she had acromegaly and she had a goiter. And mind you, this goiter may be nodular or it may not be nodular. And in some cases, it can be also hyperfunctioning. We saw one patient several years ago he was a male patient, he had a goiter and he was thyrotoxic as well, right? Acromegalic and thyrotoxic. And then they complain of breathlessness. They complain of pain and tingling in the hands. Why? Why do they complain of pain and tingling in the hands? Who can tell me?
Due to carpal tunnel syndrome or
Exactly.
peripheral neuropathy.
Exactly. Very good. Due to carpal tunnel syndrome. Very good. And if the patient doesn't complain of pain and tingling, this doesn't mean that he or she, they don't have carpal tunnel syndrome. So this means that we, as physicians, we have to elicit to look for carpal tunnel syndrome by eliciting the Phelan's and the Tinel's signs, like I'm going to show you in a while in the videos. All right. Type. Polyuria and polydipsia. Why do you think an acromegalic patient would complain of polyuria and polydipsia? Who can tell me? Who can tell me? Huh? Why does an acromegalic patient complain of polyuria and polydipsia? Who can tell me? If you don't know, just tell me for the sake of time, because I don't want to waste a lot of time on that. Huh? You studied acromegaly before, right? So you should know what is the cause of polyuria and polydipsia in an acromegalic patient. Shall I choose somebody to answer? Huh? Would you like to answer, Dr. Ala Hamid? It's Dr. Ala, right? Not Dr. Ala. Right? Can you hear me? Am I audible to you?
Maybe because of diabetes mellitus due to acromegaly.
Exactly, due to secondary diabetes mellitus. Very good, Dr. Mariam. Very good. All right, very good. Right. The next thing is muscle weakness. Mind you, muscle weakness is common among many of the endocrine diseases. Like the first one here is acromegaly. The next one is hypothyroidism. I'm going to tell you about it again. Hyperthyroidism, Cushing's syndrome, hyperparathyroidism, and so on. So, okay, so remember, and this muscle weakness tends to be proximal. It affects the shoulder and the pelvic girdle muscles, right? And again, if the patient doesn't complain of muscle weakness, you as a physician, while examining the patient to look for signs, you have to examine the nervous system looking for muscle power. You have to check the muscle power of the flexors, the extensors, the abductors, and the adductors of the shoulder and pelvic girdle muscles, okay? The next symptom is joint pains. Actually, I will tell you about a very interesting patient that I have seen a long time ago. He was a male 32-year-old patient, okay? All he complained of was what? Bilateral knee pain and clicking of the knees. He had crepitus, bilateral crepitus, okay? But when we saw the patient, so of course, the first thing he did is he went to the physical medicine and rehabilitation department. There, they noticed, of course, they examined his knees, but they noticed that the patient had acromegalic features. So the patient was referred back to us, to the endocrine unit, all right? So we noticed the patient had acromegalic features. He was wearing very thick eyeglasses due to bilateral diminution of vision several months ago. And in addition, he had very large hands, very large feet. He had a kyphotic posture, And of course, he had macroglossia. He had all the features I'm going to tell you about in a minute of acromegaly. And probing further, the patient was not married, but he was having impotence, but he was embarrassed to tell us about it. You see? So in addition, he had impotence. But all he cared about was the joint pains. You see? So the presentation can be very different from patient to patient. And so in that regard, all photographs are frequently useful to let you detect the changes in external appearance of the patient. Okay, and also some of the patients, particularly those who have macroadenoma secreting growth hormone, can complain in addition to symptoms of acromegaly that were mentioned, to symptoms of hypopituitarism. Okay, until here, any problems? Am I going too fast? Any problems?
No, doctor.
All right. Now coming to the signs, these are the things, the clinical features you detect as physicians while examining a patient with acromegaly. You will definitely notice prominent supraorbital ridges. Okay. Prognathism. What is prognathism? Who can tell me? What is the meaning of prognathism? Who can tell me?
Protrusion of the mandible.
Yes. And how do you examine for prognathism? You ask the patient to do what?
To occlusion of the jaws together.
Yes, you tell the patient, show me your teeth, please. Yani ask him to do this. Okay, so you will notice that the upper incisors are always in front of the lower incisors. This is the normal occlusion of the teeth. Okay, but in prognathism, the reverse occurs. It will happen that if you ask the patient to clench the teeth like that, this will appear. Can you see my picture? The lower incisors, how is it, are in front of the upper incisors, okay? Such that there will be malocclusion of the teeth. Why is this important? Imagine one time we had a patient, she was a female patient, and all she complained of, in addition to the change of the facial features and to amenorrhea, she complained that she couldn't bite a sandwich. She used to cut a bite by hand and put it in the mouth in order to masticate. She couldn't. Why? Because the teeth were not closing properly. So she couldn't bite the sandwich. You see, imagine this is a complaint of an acromegalic patient. Of course, not all patients complain of that. Yeah. In addition to that, there will be also what? There will be also interdental separation. The bones not only grow in length, but they also grow in width. So the normal teeth that were adjacent to each other like that, they will start separating, you see? And this may be very bothersome, particularly again to female patients. And large tongue. If you ask the patient to protrude the tongue, you will notice that there is macroglossia, like I'm going to show you in the pictures. The tongue becomes big. And what are the repercussions of a large tongue on the patient? Yani, will she complain of it or not? What do you think? Does it bother a patient to have a large tongue? What do you think?
Yes, while talking يعني ممكن مخارج الحروف تتغير.
أيوة, very good يا دكتورة مريم. The patient may complain that the speech has changed. The way they pronounce the different words has changed. فبعض patients, some patients they tell you أنا بقيت أتلعثم في الكلام. هو مش بيتلعثم ولا حاجة، بس هو حاسس إن بقه زحمة، يعني في لسانه عامل زحمة في بقه، فمش بينطق مخارج الألفاظ كويس. Okay? Very good. طيب. يعني can you see the signs? They can have various impacts on different patients. Of course, female patients complain of hirsutism. What is hirsutism? Who can tell me? What is the definition of hirsutism? What is hirsutism? Who can tell me?
Excessive hair growth?
ايوه بس مش بس كده. مين اللي جاوبت؟ دكتوره مين؟ دكتوره مريم؟ دكتوره ياسمين اللي جاوبت؟ دكتوره ياسمين. طب excessive hair growth كده في المطلق ولا you have to specify? In other words, is it possible for a male to develop hirsutism?
هي كده هايبر تريكوز. الهايبر هيرسيتيزم في يعني
لا, hypertrichosis is something else, دكتورة ماجي إبراهيم. Hypertrichosis is something else. Hypertrichosis is the hair structure itself. It's not, the hair is not terminal hair. What is the difference between terminal hair and lanugo hair? In hypertrichosis, you find lanugo hair, اللي هو الزغب ده. What is the difference between terminal hair and lanugo hair? Who can tell me?
التيرمينال hair بيكون darker و thicker.
Yes. And curled
longer.
like the, yes, and curled like the hair of a male, right? It has to be, terminal hair has to be dark, thick, curled, like the typical hair found on the body of male subjects, right? يعني معنى كده, we cannot say a male has hirsutism because the normal is that all males after puberty, they have terminal hair on their bodies, okay? So in that effect, hirsutism applies to presence of terminal hair. You have to add terminal hair, Dr. Yasmin, in androgen-dependent areas in a female. What are these androgen-dependent areas? Who can tell me? Androgen-dependent areas. What are these androgen-dependent areas?
chin والface.
Yes. The chin, زيها بقى the mustache area, يبقى the mustache and the beard and the sideburns اللي هي السوالف. This is on the face. طب where else? Where else? The upper arms, okay? Upper chest, okay? Front and back. The lower abdomen, the lower abdominal triangle. You know, in we have studied before in anatomy, the pubic hair of ladies appears how it appears like a triangle, but the base is upwards and the apex is towards the thighs, right? This is the normal pubic hair in females. But what about the pubic hair, the normal pubic hair in males? It appears lozenge shaped like that. يعني معناها it rises to the umbilicus. خلاص? طب if you find this in a female, this means that she has terminal hair in the lower abdomen or in an androgen-dependent area. And the final androgen-dependent area is the upper thighs, the medial upper aspect of the thighs, front and back. Okay? So we have a very famous score, the Ferryman-Gallwey score for detection or staging of grading hirsutism. Because مش في المطلق كده you say hirsutism and خلاص, لا. If the Ferryman-Gallwey score is more than 8, this means that this particular female patient has hirsutism. If it is less than 8, or if she has just vellus hair or lanugo hair, this is not hirsutism. This is hypertrichosis, like Dr. Maggie Ibrahim mentioned. Is it clear? Please don't get confused. Now we were talking about acromegaly, but now I'm telling you about hirsutism. Why? Because many of female acromegalic patients present actually with hirsutism. Okay, so you have, but they don't know that this is something abnormal. They don't know. They may not mention, but some of our acromegalic female patients came complaining of hirsutism. All right. Is it clear? Are you confused? Huh? Is
No.
something not clear, Tai? Okay. Let's continue. Okay, so a thick, greasy skin, this can be a symptom as well as a sign. If the patient doesn't mention it, particularly male patients, you can yourself, while examining the patient the skin of the patient, you can notice that it is greasy. كأن حاطط فازلين أو كريم أو كده. خلاص؟ Spade-like hands and feet. Spade يعني جاروف. عارفين جاروف عامل ازاي؟ مفلطح كده. Spade-like hands and feet. Of course, this also is it can be a symptom in female patients. يعني شوف ايديا بقت عامله ازاي، بقت ضخمه كده ومفلطحه. She can't complain of this. خلاص. tight rings يعني طبعا it can be also a symptom لما قالت لك increased size of the hands. بس you can ask her if she knows, she can tell you مثلا I used to wear ring size number 18 but now I'm wearing ring size number 24 لأن the fingers they grow in width. واخدين بالكم؟ بالعرض مش بالطول، بالعرض. Carpal tunnel syndrome. Of course, this is a sign. I'm going to show you a video, if time allows, on how to elicit Tinel's and Phelan's tests. Okay, to elicit carpal tunnel syndrome. And what is the mechanism of carpal tunnel syndrome in acromegaly? Who can tell me the mechanism? Why does it occur? How does it occur? Can somebody tell me? Can you tell me? Dr. Iman, you have unmuted yourself. Would you like to tell me? If you are speaking, I don't hear you. Dr. Iman, I don't hear you if you are speaking. Can somebody tell me the mechanism of or why carpal
thickening
tunnel
برضو
of a
thickening في الsynovium أو التشو.
طيب هو لا مش في الساينوفيوم بالظبط، يعني في ايه؟ هو carpal tunnel معمول من ايه؟ معمول شايفين هو carpal tunnel هنا. This is the area of the carpal tunnel. فhere you have the carpal bones on the dorsal aspect, bones خلاص, and soft tissue in front, the thinner eminences and the hypothenor eminence, and here the flexor retinaculum. Okay, so what happens in acromegaly? In acromegaly we have bony overgrowth, يعني carpal tunnel syndromes would enlarge ماشي, and we have soft tissue enlargement. فهنا برضه دول the thinner, the hypothenor, the small muscles of the hand would enlarge. فهيزنقوا على الميديان نيرف اللي هو ماشي تحت هنا من ورا ومن قدام. اوكي. synovial membrane دي يا دكتورة ياسمين دي ممكن نلاقيها في rheumatoid arthritis. When there is wrist arthritis, because carpal tunnel syndrome is not exclusive for acromegaly, by the way. You can find it in many other diseases, endocrine and non-endocrine. مين يقول لي where else we can find carpal tunnel syndrome? Where else should you look for carpal tunnel syndrome? مين يقول لي? Who can tell me?
Diabetes mellitus.
Type diabetes mellitus. Okay. What else?
Hypothyroidism.
Hypothyroidism. Very good. طب what is the mechanism of carpal tunnel syndrome in hypothyroidism يا دكتور مصطفى? What is the mechanism?
Mostly due to deposition of glycosaminoglycan or
Yes.
maybe I'm wrong.
No, it is correct. The position of mucopolysaccharide material in the carpal tunnel. So it would cause narrowing of the carpal tunnel. Excellent. Okay. Type. Which other disease?
Rheumatoid disease.
Yes, rheumatoid arthritis.
Disease.
Rheumatoid arthritis. I mentioned the mechanism just a while ago because the bovie synovitis that occurs at the wrist joint would compress the carpal tunnel. Okay. Okay. But what other non-pathological, let us call them that way, non-pathological conditions can cause carpal tunnel syndrome? Who can tell me? Sorry?
Secretary.
Yes,
Continuous
occupational,
type.
you mean? Yes, very good, Dr. Farouk. Occupational. If there is a secretary or computer, a computer engineer who is sitting in front of the laptop or the computer 8 times per day, 5 days a week for several years with poor posture, yani either hyperflexed hands or hyperextended hands, this will impact on the carpal tunnel. So this is occupational. Very good. But what else? What other conditions? Because you see, carpal tunnel syndrome is a very common condition. You will encounter it even every day. It's very common, not just related to endocrine illnesses. But what other conditions let's say
Amyloidosis?
non-pathological. Amyloidosis, yes, but how common is amyloidosis? How many cases of amyloidosis have you seen? I have seen only 2 cases since 1991, 2 cases of amyloidosis. How common is amyloidosis? Very, very rare. What common causes, but I mean, I'm talking about the common conditions, not the uncommon conditions. Who can tell me? Does simple obesity cause carpal tunnel syndrome? Can it cause carpal tunnel syndrome? Of course it can. So, pregnancy. Can pregnancy cause carpal tunnel syndrome? Yes, of course. And it is said that even after the pregnant lady delivers her child, carpal tunnel syndrome may not disappear. And this is becomes problematic. Okay. طيب يعني شايفين الشيء بالشيء يذكر حاجة بتدخلنا في حاجة بس it's important to mention يعني. طيب colonic polypi, these are important. Of course the patient will not complain. It's a sign. How will you يعني how will you suspect presence of colonic polypi? This is one question. And the second question, what is so what يعني طب لو patient عنده colonic polypi, so what? What's the importance of that? Who can tell me?
I think there's high risk of colorectal malignancy.
Yes, they can be precancerous. Very good. Okay, precancerous. So the polypi in general should be removed. And then after histopathological examination, you will be able, only after histopathological examination, you will be able to detect whether they are benign or malignant. خلاص? طيب. How can you suspect that an acromegalic patient has colonic polypi? Or is there a certain screening test you can do to detect colonic polypi in acromegalic patients? Screening, I'm not talking about colonoscopy. Colonoscopy is not a screening test. It's not a screening test. But what simple screening test can you do to suspect presence of colonic polypi? Is there anybody among you who is from the GIT unit?
Occult blood in stool?
Yes, very good, Dr. Yasmin. Occult blood in stools. So you ask about, yes, exactly. Very good, Dr. Tariq. You ask about fecal occult blood, quantitative, not qualitative. You see, if it is there, you should do a colonoscopy to detect the polypi, where they are, and possibly if you can remove by a snare and so on. خلاص? Is it clear? Any questions so far?
Excuse me, Professor
Yes, yes, tell me.
I'm not sure. Aren't we supposed to screen all patients with acromegaly?
Yes.
With colonoscopy?
It's no colonoscopy.
Initial diagnosis.
Let me tell you something. Colonoscopy is invasive, first of all, and it is expensive. You have a simpler test to screen. Occult blood in stool doesn't cost that much. Relatively inexpensive compared to colonoscopy, and also it is non-invasive. So you do it stepwise. Of course, in the back of your mind, you know that all acromegalic patients can have polypi. So this is why you have to do it. But yani, I wouldn't go extreme and do colonoscopy for all acromegalic patients, unless, of course, they have positive fecal occult blood. Okay? Does that answer your question, Dr. Farouk?
Understood. Thank you.
Okay, you're welcome. Type. Let's go back to our. Am I too slow? You just tell me. Just tell me. For the sake of time, but we have been there for 1.5 hours now. Type. Anyway, visual field effects. Visual field effects. Of course, the patient may not complain of visual field effects, but you, as a physician, you just do a confrontation test, a simple confrontation test. If it is positive, and even if you plan to send your patient for neurosurgery, before sending him or her to neurosurgery, you send your patient to do perimetry, proper perimetry at the ophthalmology department, right? Galactorrhea, as I mentioned before, it may be spontaneous. The patient will tell you about it, but if not, it may be expressible. When you squeeze the patient's nipple, milk comes out. Of course, hypertension, when you measure the blood pressure of the patient, you will find elevation of the blood pressure. This means that acromegaly can be one of the important endocrine causes of hypertension, right? Lower limb edema, heart failure, arthropathy, like the young male patient I was telling you about earlier. He had bilateral knee swelling and bilateral knee crepitus due to secondary osteoarthritis. He was 32 years old. Osteoarthritis, as you all know, is a degenerative disease of joints occurring in middle age. يعني in 40s plus, إنما ده لسه too young to develop osteoarthritis, right? So this is why it's not primary, it is secondary. خلاص. Proximal myopathy. Proximal يعني معناها the patient may not complain of muscle weakness, but if you do proper examination of the patient's flexors, extensors, abductors, and adductors of the shoulder and pelvic girdle muscles, you may find reduced muscle power. And of course, if you do urine testing by the dipsticks, you may find glucosuria due to diabetes mellitus, like somebody mentioned earlier. So far, any problems? Any problems? So these are the collective clinical manifestations found in acromegaly. Of course, you have the facial features, the coarse facial features, including enlarged nose, enlarged lips, enlarged tongue, and supraorbital bossing or enlarged prominent supraorbital ridges, the prominent cheekbones and prognathism and teeth malocclusion, and then you may have also headaches with frontal bossing and thyroid gland enlargement, okay, leading to goiter, cardiomegaly, hepatomegaly, nephromegaly, galactorrhea, particularly in ladies, increased sweating, oiliness of the skin, hypertension, splenomegaly, enlarged colon with polypi, carpal tunnel syndrome, enlarged hands, enlarged feet, and osteoarthritis. And of course, if you do the imaging on the pituitary gland or on the sella turcica, you may find a ballooned or a deformed sella turcica due to, of course, the pituitary adenoma. And don't forget the skin tags. These are very common in acromegaly, and female patients again complain of them. تيجي تقول لك شفتي الحسنات اللي طالعين لي حسنات كتير، دول مش حسنات على فكرة. These are skin tags. They may be sessile or they may be pedunculated. خلاص. Now let me show you change in appearance. As I mentioned, old photographs, this gentleman has acromegalic features. Of course, you will tell me with age it is normal. But mind you that acromegaly is an insidious disease. It occurs gradually. So if you see this patient for the first time, you may not notice the subtle changes in facial appearance. But if you follow his photograph over time, you will notice he was very handsome, but then he started to have increased size of the nose, lips, and ears, like here. See? So old photographs are useful. And you see, this is a lady, huh? She was called Mary Ann Bevan. She was telling about herself that she is the world's self-proclaimed ugliest woman. Imagine, Yani, all the social problems she might have had due to her turning into an ugly face like that. Her husband may have divorced her and so on. Okay. We had once an acromegalic patient who developed severe hirsutism, and one of the things she complained of, she said, my family life is ruined. I have 4 kids, I'm married, and I have 4 kids, and my husband just divorced me because of changed facial features and hirsutism. You see? Type. And this is the increase of the hand size. You see, the grid lines here, they are 1 centimeter apart. If you notice, if you compare the fingers of this gentleman, they are sausage shaped. عاملين زي السوسيس. شايفين? They increased in width. Not in length. Yani they would increase in length in gigantism before closure of the epiphyses, but after closure of the epiphyses, the bone tends to increase in width. So this is what makes the fingers sausage shaped. You can see this is the the patient, of course, he has acromegalic features. Okay, this is the hand of the patient compared to the treating physician. His hand size is 6.5. You see, يعني إيده كأنها غيصة في إيد العيان. Okay, شايفين؟ طيب. Of course, you cannot compare a female hand with a male hand. يعني both of them have to be of the same gender and possibly يعني preferably برضو of the same age. ماشي؟ طيب, and these are the spade-like hands. You see, زي الجاروف كده, huh? And the fingers are wide and sausage-like with increased soft tissue of the thinner and hypothenor eminences. يعني if you shake hands with an acromegalic patient, you will feel that your hand is يعني غيصة كده في إيد العيان, عايمة في إيده. Okay, and you feel a doughy sensation زي العجينة كده of the thinner and hypothenor eminences that became large. Right? Is it clear? Again, the spade-shaped hands, dorsal aspect of an acromegalic patient. And these are, you see, increased size of the hands and feet, particularly the soft tissue over the heel. خلي بالنا, heel pad thickness, increased heel pad thickness, this is a radiological sign. Don't say that in clinical examination. Okay, you just mentioned that the feet appear larger than normal with wide toes and increased soft tissue of the heel. Okay, طيب, and the face appears elongated like in this picture, you see, and the patient has prominent supraorbital ridges with prominent zygomas, large nose, large ears, thickened lips. Okay, again, you see, these are هي دي اللي بنقول عليها بقى skin tags. شايفين? These are not حسنات, huh? Ladies or female patients, they call them حسنات, طالعه لي في كل حته, particularly on the face, on the neck, on the upper chest, front and back. لا, but these are skin tags. Okay, so this patient has prominent supraorbital ridges. By the way, prominent supraorbital ridges is a normal finding in male patients, but not in female patients. فاكرين زمان in the anatomy course, we used to differentiate between the male and the female skull. Remember? One of the important differences was the prominence of the supraorbital ridges. But if you find a female patient with prominent supraorbital ridges, ده أدعى إن احنا نقول عليها عندها acromegaly. And the prominent zygomatic bone أهو باينة هنا in side view. The prognathism باينة برضو in side view, بس لازم in order to say prognathism you have to ask the patient to show you his or her teeth. ما ينفعش نقولها كده بس, ها? Then برضو prominent lips, large lips, relatively large nose and large ears. Okay. طيب, هنا برضو نفس الحكاية, prominent supraorbital ridge, prominent zygomatic bone, large nose, large ears, and برضو prognathism. Okay. هنا باين قوي بقى, بصوا شايفين؟ يعني هنا large nose, large ears, thickened lips, بالذات lower lip, ها? And prognathism. شايفين هنا بقى, شايفين? You ask the patient to show you the teeth, أو clenching the teeth. شايفين هنا the lower incisors are in front of the upper incisors. Not only that, but also there is interdental separation. The spaces in between the teeth became wider, right? This is not normal again. And here again, this patient has a large nose, very large nose, interdental separation and thickened lips and also prognathism. Okay. Here on this picture, you can see an acromegalic patient with large ears and macroglossia. You see the tongue is large. And this patient even عنده يعني واضح قوي the tongue is very large, macroglossia. Okay. طيب. لحد هنا يا جماعة, am I going too fast? Is there anything not clear? Huh? طيب, if you want to examine for bitemporal hemianopia, this is, in order best to explain what bitemporal hemianopia is, this is the normal field of vision. Imagine you are looking at those boys. You can see not only the boys holding the football in their hands, but you can see also the sides. Okay, but if there is bitemporal hemianopia, it appears as if you are looking through a tube, tubular vision. You see only the center, but not both sides. Of course, without moving the eyes and without moving the head. Huh? And this depends, يعني bitemporal hemianopia depends actually on how the tumor is compressing the optic chiasma. If it compresses from the back, from the front, from below, there may be bilateral temporal upper quadrantanopia. يعني only the upper lateral quadrants هما اللي affected. There may be lower bilateral lower temporal quadrantanopia. Only the lower lateral quadrants are affected, not necessarily bitemporal. في bitemporal في المطلق كده تبقى في upper و lower diminution of the field of vision. Is it clear? So it depends on from where the pituitary tumor is compressing the optic chiasm. Is that piece of information clear? Is that clear? Do you hear me? Where did you go? Am I talking to myself? Right. Okay.
Over here, doctor.
Okay.
Yes, doctor,
Okay.
I can hear you.
Okay. Are you tired? Are you tired? You want a break? Let's just finish
No.
the type. Okay. Let's finish the craniopharyngioma or the imaging. I mean, the imaging in acromegaly. This is important. I'm sure you have seen. How many patients of acromegaly have you seen? How many patients of acromegaly did you see? Can you please answer me? Huh?
About 3 or 4 personally.
3 or 4 type. That do you, Dr. Farouk? But what about the rest of the postgraduate students? How many patients of acromegaly did you see? Huh? The rest of
Maybe
you. 1 or 2 type. Yani imaging is important because, as I mentioned, it's not only important for the exam, but it's also important for your real life because you may be encountered even if you're not an endocrinologist, or even if you don't plan to work in endocrinology later on. Maybe you have يعني a neighbor or a friend who tells you, can you please tell me what is in this imaging? And he or she, they show you an MRI or any imaging technique of something you haven't seen before. طب what will you tell him or her? You will tell him, طب show me the report. He will tell you, unfortunately, I have lost the report. So what will you tell the patient? Will you tell him, I don't know, I didn't study this? ما ينفعش. طيب. First of all, we have plain X-rays. Plain X-rays to show what? First of all, plain X-ray on the skull in lateral view. This is very primitive, actually, but it can show you a hyperneumatized, yani excessive air in the sphenoidal and the frontal air sinuses, of course, and the maxillary air sinuses. Not only that, but it will show you an enlarged sella turcica. Okay? And it may show also an eroded anterior or posterior clinoid surface processes. Not only that, but it may also show you a double floor. This is actually the normal anatomy of the sella turcica in plain X-ray. And this is how it looks like in acromegaly. You see? You see there is thickening of the skull vault. It's very thick. And then you have hyperneumatization of the frontal, the sphenoidal, and the maxillary air sinuses, the paranasal sinuses. And there is ballooning of the sella turcica. If you compare it to the previous slide, this is the normal. Normally, it should accommodate only the tip of the little finger. You see? But here you can see it's ballooned. مش بس كده, there is also mandibular prognathism. Here you can see elongation of the mandible. You see, the lower incisors are in front of the upper incisors, but here the patient was asked to open the mouth. So this is the typical plain X-ray skull lateral view. Of course, when you are given a radiology, سواء in writing في written exam or in the word في clinical exam, you have to say what this imaging technique is, whether plain X-ray, CT, MRI, scintigraphy, whatever. And the view, lateral view, عشان in order to get the full mark. And then برضه في MRI, is it sagittal, is it coronal, خلاص, is it T1 weighted, is it T2 weighted, and so on. Is it with contrast, without contrast? Very important. Okay, so this is the plain X-ray skull lateral view. اهي هنا اهو شايفين في thickening of the skull vault, برضو hyperpneumatization of the frontal and the maxillary air sinuses. Here prognathism is very evident because here the patient was filmed while showing the teeth. The lower incisors are definitely in front of the upper incisors. Is it clear? واضح يا جماعة؟ طيب. Now, طيب, very good. Now we see another imaging modality that is important, plain X-ray of the hands. It will show what? Increased bone density. You see, as if the bone appears whiter than usual. Increased epiphyseal widening. طيب, why is there epiphyseal widening? مش بس كده كمان في يعني there is joint space widening. Why is this? Why does this occur? Who can tell me? The joint space appears widened. Why is that? Who can tell me? Who can tell me يا جماعة? For the sake of time, if you don't know, just tell me. I don't know. We are wasting a lot of time. Because of the enlarged cartilage. But it will, cartilage on X-ray, on plain X-ray appears gray or appears black. خلاص? It appears as if the joint spaces are enlarged. خلاص? طيب. And if you look closely here, you will find the terminal phalanx. It appears mushroom shaped. This is what we call tufting of the terminal phalanges. Don't mention this as a clinical sign, please, because it is not a clinical sign. This is a radiological sign. خلاص? Okay, is it clear? اهو tufting شايفين؟ عاملة زي المشروم. Where is my cursor? شايفين عامل ازاي؟ It appears like a mushroom. اهو. Okay, this is in close up. So this is tufting of the terminal phalanges in plain X-ray of the hand of an acromegalic patient. ماشي؟ طيب. Regarding the plain X-ray of the feet, this is what we call increased heel pad thickness. ماشي يا جماعة؟ Increased heel pad thickness. في الكلينيكال كنا شايفين ان ال soft tissue of the heel is enlarged. But in lateral X-ray of the left foot, L اهي for left, هنا باين لنا ايه؟ باين لنا increased heel pad thickness. Okay? This is also again a radiological sign, not a clinical sign. Is it clear? Now coming to the MRI on the sella turcica. Very important. You know that pituitary tumors or pituitary adenomas can be subdivided according to their size into microadenoma, which is a pituitary adenoma less than 1 centimeter in all dimensions. ماشي يعني craniocaudal, side to side, anteroposterior. ماشي 1 centimeter, less than 1 centimeter أو less than 10 millimeters. خلاص؟ طيب. This is a close up of, this is which view? Is it a sagittal or a coronal view of the MRI? Who can tell me?
Coronal view.
Coronal. And this one is what view?
No, coronal also.
Very good. Coronal. Type. Let me show you. This is the anatomy. This is which structure is that? I'm asking you. Which structure is this?
Sphenoid sinus.
Yes. Sphenoid sinus. Very good. And the white, the black structure here and there. What is this?
Carotid artery.
Very good. Type. What is this white structure here?
Cavernous. لا. Cavernous sinus.
لا. Cavernous sinus ده. Okay. لا. This structure.
Internal jugular vein.
Sorry?
Internal jugular vein.
No. This is the sella turcica. This is the bone. The bony boundaries of the pituitary fossa. ماشي؟ طب inside, this is what? The gray, the light gray. The light gray is what? You see? There is a dark spot here, a dark structure, and it's surrounded by a grayish white structure. What is this? And it has like a tail here. What is this? What is this structure? This is the pituitary gland, يا جماعة. This is the pituitary gland. But this is, when you comment on this picture, you see, you say this is an MRI, a sella turcica, T1 weighted image, right? Coronal view, T1 weighted, because here the CSF appears black. ماشي? Coronal view with contrast. Why do I say it's with contrast? Because when you give gadolinium is the contrast used to visualize the pituitary gland. The pituitary becomes enhanced, yani it takes up the contrast, while the micro or the macro adenoma doesn't take up the contrast. This is why it appears like a lucent intracellular lesion. يعني ايه lucent؟ يعني معناها غامقة. It appears dark. So this is the pituitary gland, and you will notice that the upper border appears convex, and the stalk, this is the pituitary stalk. I told you it should be central, but here it's deviated to the left side. You see? Okay. And this is another structure, MRI of the pituitary gland, coronal cut with contrast again. Okay, showing again, this is the area of the sphenoidal sinus, and this is the sella turcica itself, and this is the pituitary gland that appears white in color because the patient was given contrast. And the upper border of the pituitary appears برضه convex. شايفين? And there is a left-sided lucent intracellular microadenoma. And here the pituitary stalk is shifted to the right. Okay? You see here R for right, L for left. So it's shifted, it's not central. Is it clear? So this is how a pituitary microadenoma looks like. Is it clear? Any problems? Any problems so far? Can you hear me?
Yes.
Right. Okay.
Yes, doctor.
Right. Okay. Now, this is how a pituitary macroadenoma looks like. A macroadenoma is a pituitary tumor that is more than 10 millimeters or more than 1 centimeter in size. Okay. Again, this is, who can tell me this is what? What cut is that?
MRI sella turcica, T1.
Yes. Yes.
coronal.
Exactly. Type showing what? This is, again, this is the sphenoidal sinus, full of air, black. This is the carotid artery in the cavernous sinus. And all of this is the pituitary gland, you see? It's expanding the sella turcica and even encroaching on the left cavernous sinus, you see? And this is the stalk. You see the stalk is deviated to the left side, and the pituitary gland has a convex upper border. So this is a pituitary macroadenoma with moderate supracellular extension compressing the optic chiasma. This is the optic chiasma, you see. Normally there should be a space like here between the upper border of the sella turcica and the optic chiasma, okay? Like here again, but here you see it encroaches, there is supracellular extension encroaching on the optic chiasma. Is it clear? Right. Now this picture on the right-hand side, what does it represent? Who can tell me?
Sagittal view. MRI sella turcica, T1
Yes.
sagittal view.
Exactly, very good. So this is an MRI of the sella turcica, sagittal view, T1 weighted image showing a huge macroadenoma. You see all the black arrows point at this is here is the area of the pituitary, but it extended supracellularly until the hypothalamus. It invaded the hypothalamus and even reaching to the third ventricle. You see? You see? It's a huge macroadenoma with moderate supracellular extension. Okay? Very good. Now, this is another MRI, sella turcica or pituitary gland, Bordeaux in sagittal view, T1 weighted image because the CSF appears black, with contrast showing this is a pituitary macroadenoma. Now, can you just by looking at the MRI say if this is a growth hormone secreting macroadenoma or a prolactinoma or something else, just by looking at the imaging? Is it possible for you to detect this? Who can tell me?
الكرانيوفارينجيوما بس اللي بيبقى فيها calcification
Yes, very good, very good. But I mean, can you just by if I didn't write acromegaly here, can you say for sure just by looking at the imaging that it is a patient with acromegaly that has a pituitary macroadenoma? No.
هو
No.
الاكروميجالي بيبقى ماكرو ادينوما while prolactinoma مثلا
Yes.
بتكون مايكرو mostly.
Yes, but in male patients, for instance, prolactinomas tend to be macroprolactinomas. But just by looking at the MRI, what I want to say is that just by looking at the MRI, you cannot say whether this is a growth hormone secreting pituitary tumor or a prolactin secreting tumor and so on. So this is why in endocrinology, while investigating any patient, we first do the hormonal profile and then we do the imaging. Okay? Is it clear? Not the reverse. Okay? Type. And this is another, who can tell me about, yalla, comment. You comment on this. Who would like to comment on this picture? Yalla, who would like to comment?
It's an MRI coronal view T1.
Yes.
Showing
MRI on which region? You didn't mention. Is it abdomen? Is it pituitary? Is it brain? Because it's different. If you say MRI brain, they will not they will not show the cuts of the pituitary. Okay? If you mention MRI pituitary, they will do the cuts of the pituitary. So you have to be specific, Bordeaux, in describing. Okay?
Okay.
So this is
showing
yes.
a macroadenoma
Yes.
extending to the right cavernous sinus.
Exactly. This is طبعا here they used Bordeaux contrast. Why? Because the pituitary gland appears white, so it is enhanced. It took up the contrast, while you see the filling defect or the lucent area is the adenoma. But here the tumor is relatively big because it has expanded the sella turcica and encroaching to the right cavernous sinus. But there is no supracellular extension. There is still a space between the upper border of the pituitary and the optic chiasm. Very good. Okay, now craniopharyngioma. Craniopharyngioma is actually not a pituitary tumor. It doesn't arise from the pituitary because it arises from Rathke's pouch. Rathke's pouch is an embryonic remnant that is above supracellular. It's supracellular. And it's better detected by, like I will show you, it is better detected by CT, not by MRI, because it has a lot of a cystic component and a calcified rim and so on. And it is actually the most common pituitary tumor in children, and it may present at any age. Okay. The youngest patient I have seen with craniopharyngioma was 10 years old. He was a male. He was a boy. He presented with what? The presentation was very odd. At the age of 4 years, he started having nocturnal enuresis. So his mother brought him to a physician. I don't know the specialty. I don't remember. He gave him medications, but he didn't improve. At the same time, he started complaining of headaches and diminution of vision bilaterally. Until the age of 10 years, for 6 years, the patient has been neglected until he presented to us at the endocrine unit. He had short stature, he had polyuria, polydipsia, and unfortunately, he was bilaterally blind. Why? Because the headache was due to, of course, an increased intracranial tension, which caused bilateral papilledema, followed by post-papilledematous optic atrophy bilaterally. So he was a very miserable patient. Nobody diagnosed him early. Instead of diagnosing nocturnal enuresis, they should have diagnosed a craniopharyngoma and treated him very early to save at least his eyesight. Okay, so it's usually a cystic hypothalamic tumor, so it's above the sella, above the pituitary. But it may be so large as to erode the area of the pituitary, and during my residency a long time ago, I have actually seen a female patient. She was like 18 years old. She was admitted to the ENT department. You will tell me why. Why did a craniopharyngoma patient go to the ENT department? I will tell you why. Actually, she presented there with tumors coming out of both nostrils. So her parents were clever enough to think this is something to have to do with something that has to do with the nose. So let us bring her to ENT type. So she was admitted, but then I was consulted to go see this patient. But I noticed the patient was short. She was 18 years old, but she looked like a 10-year-old child. She didn't have any breasts. She didn't have any pubic hair. She didn't have menstruation at the age of 18. يعني معناها delayed puberty. She had postural hypotension, and she had secondary hypothyroidism. In addition, she had also polyuria and polydipsia, and she was bilaterally blind. So this means what? I asked them, did you do back then it was in the early 90s. In the early 90s, we didn't have a MRI yet at the Miri Hospital, at the main university hospital. So at least do a CT. So I asked them to do a CT of the sella turcica. And I will show you the picture how it was. It was, this is not the CT of the patient, of course, but we found out that it was a craniopharyngoma that was very huge, eroding the pituitary and the floor of the sella turcica and the cribriform plate of the ethmoid going down to the nose. And it's often calcified. It arises from Rathke's pouch. So it often mimics an intrinsic pituitary lesion, but it is not. Okay. So when you do a plain X-ray of the skull, like in the acromegaly, you will find, you see, this is the sella turcica. You will find that it is eroded. But if you look closely here, there is a white speck of calcification, supracellar. This is the cellar region, but supracellar. So this means that the tumor is here. So this is definitely a craniopharyngoma going down to the pituitary gland. And this is the MRI, the coronal MRI showing, Bordeaux, it's a coronal MRI in T1 weighted image. You see, these are the ventricles filled with the CSF that appears black, but the patient has hydrocephalus. You see, the ventricles are dilated because this large tumor, which appears like a cyst with a contrast enhanced shell. Okay, this has caused obstruction of the ventricles, causing hydrocephalus. But this is the typical CT picture. Unenhanced. Unenhanced means this is a CT without contrast. This is axial. Axial, yani the cut is like that. If you can see me, the cut through the forehead. So this is the bone appears white. Okay, this is the skull bone, and the brain tissue appears gray in color. CSF appears dark black like that here. You see, and this is the area of the supracellar. This is supracellar. Why does it appear white like that? You see, a white structure like that, having the same tissue density like bone, is calcium. So this is a cystic structure with calcifications in the suprasellar region, again with hydrocephalus. The lateral ventricles and they are dilated. Okay, is it clear? This is how craniopharyngioma looks like. Okay, is it clear?
Yes.
Okay, so would you like us to stop here or shall we continue? Because I wanted to discuss thyroid diseases with you. Thyroid diseases include hypo and hyperthyroidism in addition to thyroid nodules. There is a lot to discuss. So as you like. When is your exam? The final exam? Has it been set yet, the date?
Yes.
December
31.
31st.
This December 31st. Type. Yani we have today is the 10th. Yeah, we have like 2 more weeks to go. Right? Type. So would you, we have been for 2 hours now discussing. Would you like to continue today or after a break? Or would you like to us to continue next week? But next week, remember, we have additional things to discuss. We have still the parathyroid diseases to revise and all the adrenal diseases and so on. So we have a lot to cover. Yeah, I'm free to suggestions. You tell me. What is it you like? Huh?
Can we do it next week?
ممكن نكمل يا دكتور.
طب let's vote. Let's vote. I have now how many students with me? I have 7 students. Would you please show me your hands? Raise your hands. Who wants to continue today? Raise your hand. دكتورة ماجي إبراهيم. طيب, the only
هو
one.
أنا مش عارفة ازاي raise my hands بس أنا عايزة أكمل النهاردة.
طيب, دكتورة مريم, guest, and Dr. Ahmed Samir. 3 out of, and the rest of you, how about the rest of you? 3 out of 7. Minority يعني.
Next time.
Next time. طيب, دكتورة إيمان. دكتورة إيمان guest. I don't hear you. Yani if there seems to be a problem in your microphone. If you can, please write in the chat because I don't hear you at all. Yani. Yes, Dr. Tariq. You want today to continue? Dr. Tariq, you have raised your hand lately. Dr. Iman says next time. There are 2, yani Dr. Farouk and Dr. Iman want next time. What about the rest of you? Yani I have Dr. Tariq, I didn't understand. You raised your hand. You wanted to ask me a question or you wanted to continue today or what? Can you, where is Dr. Tariq? He seems to be disconnected now. طيب, يعني وفاضل مين كمان؟ دكتورة مريم, حضرتك قلتي لي you want to continue? دكتورة
Yes.
مريم guest. طيب, يعني زي ما انتوا عايزين. Dr. Yasmin برضو was disconnected. Dr. Yasmin, you want to continue or you want to continue next week, inshallah? Dr. Yasmin.
Next week يا دكتور لو
Next week. طيب, okay. طيب, يعني احنا عندنا دلوقتي كام؟ قالوا next week. حد بيعد 3 ولا 4؟ ما فهمتش انا دكتور طارق اصلا قبل ما يبقى disconnected رفع ايده ليه؟ عايز today ولا next week؟ عشان لو today هيبقى 4 يعني majority. فاهمين؟ This is why I'm asking. هنا في الشات عندي دكتورة إيمان. دكتورة إيمان قالت لي next time. طيب, يعني زي ما انتوا عايزين. زي ما انتوا عايزين. If you like to continue next week, يبقى I will have a 3rd revision session. I will have a 3rd revision session. ليه؟ لأن we have a lot to cover. الهايبو والهايبرثايروديزم والهايبو والهايبرباراثايروديزم والهايبوباراثايروديزم. الادرينال بقى دي لوحدها قصة تانية. عندنا الكوشينج وعندنا الاديسون وعندنا الكونز وعندنا فيوكروموسايتوما. ف there is a lot to revise يعني. فزي ما انتوا عايزين. I'm open to suggestions. You can lower your hands, by the way, Dr. Maggie and Dr. Ahmed Samir. Thank you. Yes, Dr. Maggie, you have raised your hand again. طيب. Okay. فقولوا لي بقى, if you like to continue next week, يبقى we will have a 3rd revision session. Okay?
تمام يا دكتور إن شاء الله
طيب.
لو ينفع مع بقية زمايلي يعني.
طيب ماشي خلاص no problem. بس بليز يعني أنا عارفة إن عددكم أكتر من كده. I know أنتوا تقريبا 23 مثلا master degree students and you are like 3 or 4 doctor degree students. أنا مش شايفة منهم غير يمكن الدكتور طارق بس، صح كده؟ دكتور
هو احنا تلاتة دكتوراه، أنا ومريم
دكتورة ماجي ودكتورة مريم ودكتور طارق، 3 يعني انتوا 3 دكتور. طب الماجستير انا شايفه 4 بس، من كام؟ من 23. انتوا كام ماجستير يا دكتورة مين؟ دكتورة ياسمين متحدث الرسمي. دكتورة ياسمين حضرتك انتوا كام في الماجستير؟
مش عارفة بالتقريب كام يا دكتور بصراحة، بس هم حاجة 20 أظن.
طيب انا عارفه. طيب يعني لما يحضر 4 من 23 this is very يعني very poor attendance. By the way, you're not attending for yourself يعني or for the attendance, for the sake of attendance. You are attending for your own sake يعني. Huh? I know this, but you are the ones who need to revise. Okay. Anyway, so يبقى next week إن شاء الله. طيب is it okay to have the same time يعني 7 o'clock, or would you like to make it later? Would you like to make it earlier? Tell me. You tell me.
يا ريت لو 8 يا دكتور.
8. طيب all of you agree about 8? ها؟
I agree يا دكتور تمام.
طيب بقية الناس. طيب ما بقية الناس، ما احنا معايا دلوقتي أنا 6 students. طيب what about
تمام يا دكتور إن شاء الله.
تمام. طيب يبقى 8. خلوني بس افتكر اقول للدكتور احمد عشان يبلغكم الحاجه كمان برضو. let me put in the chat. I need you to evaluate today's session please before you leave. Okay. انا هحطها لكم دلوقتي في الشات. Can you see the link in the chat? Can you see the link in the chat?
لا يا دكتور.
ما هي محطوطة اهي. اتبعتت. اتبعتتش؟ اتبعتت. sent بس هي ما وصلتش يمكن. انا ما عنديش
لا
وسيلة.
يا دكتور واضحة، وصلت موجودة.
وصلت. طيب حضرتك يا دكتور احمد سمير لو تسمح. Can all of you see the link for the
Yes أنا شايفاها.
Okay, great. Okay, now I'm going to stop sharing my slides and I'm going to start sharing the evaluation just to show you. It's very simple. The questions are very simple. 1 minute. Can you see my screen? This is how it looks like. You have to put your official email, an optional email, for example, a Gmail or Yahoo, whatever. Your rank, if you are an assistant lecturer, resident, master degree student, doctor degree student, or other. And then the first revision session added much to my knowledge and clinical skills. The timing of the session was appropriate. And the discussion added much to my knowledge and clinical skills. Microsoft Teams is easy to use. The sound quality was good. Overall, how satisfied are you with the webinar? What did you like most about the webinar? And what would you like? What would you suggest to improve the webinar? Okay. Until now, nobody answered. All right. But if you see 0 responses. When you start answering, I'm going to see numbers. Of course, you are free to write whatever you like because I have no way of knowing who wrote what. But you are 6 students, so I expect to have 6 responses, please. Okay? So would you please start
هو
answering?
أنا مش طالع لي اللينك يا دكتور للأسف في الشات.
مين حضرتك؟ مين؟ دكتورة مريم؟
أنا
دكتورة ياسمين؟ طيب دكتور أحمد سمير, can you see the link? If so, can you please put it on the WhatsApp group, please, because I have no way of reaching you. دكتور أحمد سمير.
تمام يا دكتور حاضر تمام.
يلا اتفضل. طيب I expect to find 6 answers, please. Right? Can you still see my screen?
أيوة يا دكتور أيوة.
طيب شايفين محدش جاوب اهو لسه. اول ما حد هيجاوب هيبان ارقام يعني هتشوفوا دلوقتي. Dr. Farouk is still with us. Dr. Farouk, are you? Yes. Did you see the link? Dr. Farouk, could you find the link? you have an issue with your email. 1 minute. كاتب لي هو ايه as soon as possible. لا يعني I prefer that you give me your feedback today, Dr. Farouk, because if you postpone, I'm sure you're not going to do it. I need your feedback today, please. Okay?
Yes. I have an issue with the Alex made the email.
No problem. You can write, just write, leave the first part empty and then at alexmed.edu.eg. All right? Because it is a required field. You have to fill it out. Okay?
Okay.
Thank you. So now I have one response. Oh, let me show you. Where is the response? Yes. First response, doctor degree student, assistant lecturer. Okay. 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 And may I please ask those of you who filled out the survey to remain with me online until all of you finish, because it's always nice to know what other people think. You know what you wrote, but you don't know what your colleagues wrote, all right? So please stay online so that I will read to you the responses of your colleagues. So can you please hurry up? Still 4 missing. Type 3. Oh, okay. Okay. Can you still see my screen?
Yes, doctor.
Now somebody wants to start earlier, but some of you, who was it, Dr. Yasmin? You want to start at 8. So what shall I do? Start earlier or start later? This is when the conflict arises. Right, yalla, the rest of you. You see the importance of the questionnaire, because according to this feedback, I can change the way I teach online. Type covering nearly the whole details. Okay. طيب يلا the two remaining يا جماعة، الاثنين اللي فاضلين فين عشان نخلص بقى. يلا. يلا يا جماعة الاثنين اللي فاضلين. ها. في حد معرفش يفتح اللينك أو معرفش يوصل لللينك؟ 5. اوكي. فاضل حد واحد. يلا. حد واحد. اوكي. حد واحد يا جماعة. One student remaining. Dr. Yasmin, can you please make an announcement on the WhatsApp group for postgraduate students that you have sent the link, right? We were like 14. يعني أكتر عدد حضر النهاردة من الطلبة كانوا 14. فاللي فضل منكم للآخر 6. Can you please ask the 8 students who attended برضو to fill out this questionnaire for me, please? دكتورة ياسمين.
حاضر يا دكتور.
عشان
حاضر
بس
يا
انا
دكتور،
ما
هبعتهم
عنديش
دلوقتي.
لينك ليكم، انا مش في المجموعه بتاعت الواتساب بتاعتكم. اوكي.
هبلغهم دلوقتي.
لو
حاضر.
تسمحي طيب فاضل
حاضر.
one student remaining. مين اللي مش عايز؟ مين اللي محجم؟ يلا مين اللي فاضل؟ طيب اوكي until he or she بقى answers let me read out the answers. احنا معانا هنا 40% master degree students و 20% doctor degree students و 20% assistant lecturers with 20% residents. Okay. The first revision session added much to my knowledge and clinical skills. كلكم strongly agree. The timing of the session was appropriate. 80% strongly agree, 20% agree. The discussion added much to my knowledge and clinical skills. All of you strongly agree. Microsoft Teams is easy to use. 60% strongly agree, 40% agree. The sound quality was good. All of you agree. Strongly agree. Overall, how satisfied are you with the webinar? 80%, very satisfied, 20% satisfied. What did you like most about the webinar? The revision is very rich and useful. The lecture content, very informative, and I love the explanation of the imaging. Yes, yes, I believe that most of you have a big defect in imaging. This is why I made it a point to revise it. Yeah, the revision covering nearly the whole details. I think you did a great job. Thank you very much. Thank you. It's my job, by the way, to explain to you what you don't understand or what I think you may have difficulties with. Clinical knowledge was well elaborated. What would you suggest to improve the webinar? Nothing. Case presentation of some cases. Start earlier. I don't know if we should start earlier or later, depending upon the request of some of you. I don't know. يعني انتوا اتفقوا مع بعض بقى وقولوا لي ها الديسيجن الفاينل من خلال الدكتور احمد علاء يعني. Nothing more interaction is needed. Yes, I believe that too. Because I'm trying to ask you, but you don't answer. I don't know why. يعني هل technical problems with Microsoft Teams, ولا you don't know, ولا you are shy to answer. I don't know why you don't interact. So يعني try next time please to be more interactive. Okay? Any suggestions? Any comments? Please feel free. I'm here for you. لو عايزيني أغير حاجة أعمل حاجة بطريقة معينة قولوا لي برضه.
Thank you, doctor, so much for this revision.
You are most welcome. I hope next time, inshallah, we will cover more things. And please be prepared because there will be also questions برضه زي المرة دي يعني ها. And يعني I would like to see you يعني if possible, if you can open the video camera while commenting, that would be great. Okay? Okay? Anything else you want to suggest? Shall we start earlier or later, like some of you suggested? Yani, I don't know.
I think later is better. 7 or 8, not earlier than 7.
طيب يعني اتفقوا معايا مع بعض يا دكتورة مريم and let me know please through Dr. Ahmed Ali before I send you the link. All right, because next week it's going to be a different link. Regarding the video recording, how you can access the video recording, I will tell you how after we finish today and we all leave. Can you see still my screen? Let me see. يعني بصوا, I will show you how it's. Can you see my screen now? Huh? Can you see my screen?
Yes, doctor.
Type. You see, after I'm using my laptop, so after we leave, I'm going to click on leave. خلاص? Type. And then you log in again through the link that Dr. Ahmed Ali has sent you. خلاص? And here you will find in the chat, you see, you open the chat, you will find something like this. Appears video recording is ready. خلاص? You will click on these 3 dots. You will have 3 options: open link or يعني open link. If you click on open link, another window opens, the one that you have to log in with your your official email account at alexmed.edu.eg. خلاص? This is when you log in with your official email, you will be able to see the video recording. Okay? Is it clear? Any problems?
No, Dr. شكرا.
Dr. Iman is writing something. Okay, I will have to wait until
لا يا
she.
دكتور تمام شكرا.
العفو يا دكتور أحمد. Dr. Iman, I suggest that yes, you are most welcome, Dr. Iman. Thank you very much. But I suggest, for your sake, Yani, please try to solve the issue with your microphone because I would like to hear your participation, your active participation in the meeting, please. Okay. Type. Dr. Iman is writing and Dr. Farouk is also writing. Okay. Okay, you're most welcome, Dr. Farouk. Dr. Farouk, where are you from? Are you registered at the endocrine unit? I think you were with us several semesters ago. Are you the one?
Yes, but I'm doing a clinical training. I have special interest in the department.
Yeah. You are. I think you are the batch of Dr. Saeed, right? Dr. Saeed Ahmed from Kenya.
He's from Kenya. Yeah. I'm
Yeah,
also from Kenya.
You are also from Kenya. Very good. Very good.
Yes.
Ahlan wa sahlan. You're most welcome to attend with us. Okay, and there was one of your a consultant. He was also from Kenya. His name was I don't remember his name. He had a 6
Here,
months
that is-
training. Is he still here, or
He
did he
just-
go back?
He left today, actually. He left today, early today.
Okay. Did he finish already his
And I'm
6
also-
months? Did he finish his
Yes,
6 months? How time
yes,
flies.
I'm leaving January, first week of January.
Oh. Best of luck. How long have you been here in Alexandria, Dr. Farouk?
I did my master's here.
And at which department were you registered? For the
Internal
thesis, I
medicine.
mean. No, I mean for the thesis. For the thesis.
I did rheumatology under Professor Anna.
Very good. Very good. Type, excellent, excellent. But you want to be an endocrinologist?
Yes, definitely.
Okay, that's good. That's good. Okay.
Thank you.
خلاص يعني I'm waiting for you next Sunday inshallah and decide on the time. I don't have any problems with any time you prefer. And just let me know so that I can send you the link. All right. Thank you very much for your active participation and for your patience above all with my lengthy explanation at times. And I wish you a pleasant evening. Assalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم السلام يا دكتور.